So for those of you joining us, you're here, hopefully, session 322, Test Your Cancer, Genomic Cancer Testing Overview. And we're here with Sherry Bates, Catherine Shapley, and Valentina Tarasova, MD. I'm Abby Melendez. I'm a ThyCa volunteer. Sherry Bates is an oncology nurse educator on the precision medicine team at Bayer Healthcare Pharmaceuticals, based out of the state of Washington. Prior to transitioning to a nurse educator role in 2017, she held the position of oncology nurse navigator at UW Medicine Valley Medical Center in Renton, Washington. Her clinical background encompasses experience in neuro-oncology, community practice, and specialty case management. She holds certifications in oncology nursing, case management, and care coordination and transition management. We also have Catherine Shapley, MSN RN, who is an oncology nurse on the precision medical team at Bayer Healthcare Pharmaceuticals, located in the Southwest region. Catherine educates healthcare professionals in the adult and pediatric settings on adverse event management and oncology disease states. She spent the majority of her clinical career in an outpatient adult oncology hematology practice in northern Mississippi. She completed her Bachelor of Science in Nursing and recently earned a master's degree in nursing administration and leadership from South University in Savannah, Georgia. Anjali, our other ThyCa volunteer, will introduce Dr. Tarasova. Anjali? Thanks.
Everyone. Dr. Tarasova is an endocrinologist at Moffitt Cancer Center in Tampa, Florida. She received her MD at Kubenski State Medical University. She completed an internal medicine residency at Yale New Haven Hospital, Yale School of Medicine in New Haven, Connecticut, and in endocrinology, diabetes, and metabolism fellowship at the University of Omaha, Nebraska. Most recently, Dr. Tarasova completed a thyroid cancer fellowship at Memorial Sloan Kettering Cancer Center. Dr. Tarasova's clinical interests include thyroid neoplasm, particularly diagnosis, monitoring, and treatment of thyroid carcinoma from low risk to advanced progressive forms of thyroid cancer. Her research interests include the role of molecular markers in diagnosing and determining the prognosis of thyroid neoplasm, risk stratification of patients with thyroid cancer, and developing tools to estimate the prognosis and determine the management of patients with thyroid cancer. Welcome, all of you. Thank you.
Thank you. Thank you for the lovely introductions. And also, thank you, ThyCa, for having us back this year. We want to welcome everyone, and thank you for joining this session. I am, as introduced, Sherry Bates, and joining me is my colleague, Catherine Shapley. We are both nurse educators at Bayer, and we are presenting this presentation today on genomic cancer testing overview and Test Your Cancer on behalf of Bayer. Looking at today's agenda, we're going to talk about, well, what is genomic cancer testing? What are these terms that go along with it? How can that impact cancer and the development of cancer? What is an example of a genomic alteration? And look at some tumor types commonly associated. Also, why does it matter? Why does this testing even matter? And what does the process look like when testing a tissue sample? And most importantly, a takeaway for today is, how do I talk to my doctor about genomic testing, and where can I get more information? Kathy, you want to get us started?
Yes. So thanks for having me, everyone. So there are many scientific terms used when it comes to genomic testing. commonly referred to as biomarker testing. So I wanted to take a moment just to speak to a couple of these, and you're going to hear these terms throughout our presentation. So gene, you've heard genomic alteration, genomic cancer testing. I do want to mention this. It's used to identify unique DNA alterations or changes within cancer cells that determine how a tumor behaves and why it grows. Genetic testing, these two terms can be used interchangeably. However, they are quite different and should not be. So genetic testing is going to look at the inherited traits passed from generation to generation and can evaluate someone's risk of getting cancer. We'll talk about gene fusion. We'll talk about next generation sequencing. NTRK gene fusion we'll mention. And I'd like to mention NTRK stands for neurotrophic receptor tyrosine kinase. And then we'll also mention TRK fusion protein, which is your tropomyosin receptor kinase. Biomarkers, we'll talk about gene mutations, inherited mutations, which I mentioned that will be identified from your genetic testing. We'll talk about clinical trial, investigational treatment, targeted therapy, and I do want to mention tumor agnostic treatment. So this is really therapy based on the molecular makeup of a cancer rather than where it started in the body. So cancer has historically been classified by tumor tissue type, also known as histology. Science has shown that some DNA cancers are driven by DNA changes called genomic alterations, which can occur in many different locations. Some alterations may drive the growth and spread of a tumor, and sometimes called an acquired mutation, biomarker, and gene mutation. Tumors driven by genomic alterations are not limited to certain types of cells or tissues, so can occur in any part of the body. Genomic testing is the only way to find out whether genomic alterations exist in that tumor. So now we're going to talk about NTRK gene fusion as one type of genomic alteration. There are several types of genomic alterations which can occur in select solid tumors, such as KRAS, you may have heard of, HER2, BRAF, EGFR, ALK, ROS, and then NTRK and many more. TRK fusion cancer is caused when NTRK genes join or fuses with a different unrelated gene known as a genomic alteration. It can drive the growth and spread of cancer. The fusions produce certain proteins that can cause a tumor to grow or spread. So when the TRK fusion proteins are turned on, they become overactive and cause a tumor to grow and spread. It's kind of like if the gas pedal's turned on and they are just causing that to be overactive and constantly on. And if you look over to the right side, I guess your right side, it gives you an estimated NTRK gene fusion frequency in select solid tumors. So these are just some examples. Lung up to 3.3, thyroid up to 12%, glioblastoma 1.2%, certain pediatric tumors 10 to 100%, GI cancers 0.7 to 3.6, sarcoma 1%, and then salivary up to 100%. So that gives you some examples of the frequency in some of the solid tumors. Now we're going to go on to give you some examples. Sherry?
Thanks, Kathy.
Yeah.
So let's look at the importance of genomic testing in actionable alterations in head and neck cancer. We are here for the ThyCa conference today. More than 90% of thyroid cancer cases have at least one genomic alteration. Head and neck cancers are examples that, of course, may contain some of these alterations, and they may, in some cases, include an NTRK gene fusion. And although NTRK is rare, it's still important to test for it, and that's the message here today. And the only way to know is to look at the genomic testing and look at the alterations, and there can be others outside of NTRK. You know, some other examples are the BRAF and RET that are included here at the bottom of the slide. So it's important that every patient with an actionable genomic alteration be identified. So actionable means that there's a therapy to treat that alteration. And so next slide, Kathy. Pediatric solid tumors. We want to talk about that for just a minute. Approximately 50% of pediatric cancers potentially have a targetable alteration. And you can see here that in some cases, up to 100% of pediatric cancers may have an NTRK gene fusion that lists infantile fibrosarcoma, congenital mesoblastic nephroma, papillary thyroid cancer, and high-grade gliomas as some of the examples. Again, testing is the key to finding these alterations. And we mentioned NTRK, of course, but also looking at BRAF and ALK in some of these patients. And we want to find every patient possible that has an alteration and can be treated so they can receive the benefit of therapies that might be available to them.
So I'll mention the last one. This one's kind of dear to my heart. I did have a loved one that had colorectal cancer and that did have this alteration. So I know we're here for ThyCa, so it's just important to think about any family or friends, you know, in regards to colon cancer. I mean, colon cancer is one of the most common malignancies arising from our GI tract. Third most common cancer in men, second most common in women, and up to 95% of colorectal cases stem from the non-hereditary mutations and genomic alterations. NTRK gene fusions can be more common in certain colorectal cancers, like those with a biomarker called a microsatellite unstable, or MSI for short. But like Sherry mentioned on previous slides as well, the only way that we can identify these is through testing. This can identify your NTRK as well as KRAS and NRAS. So why genomic testing matters? First, it's important to note genomic cancer testing is a crucial step in diagnosis. A genomic test paints a more precise picture of a person's individual cancer. So up to 49% of patients who undergo testing find an actionable alteration, which means they could be matched to either an approved therapy or a drug in clinical trial. And there's over 100 targeted therapies that are currently approved by the FDA, with more in development.
And when embarking on the cancer journey, it's important to understand the full picture of your cancer. So if you think of genomic cancer testing like the GPS, you know, you wouldn't want to get in the car and leave the driveway without having directions on where you're going to go. So it's important to get all the information you can about your tumor before starting treatment, if possible. And genomic testing identifies a patient's unique alterations or changes within the cancer cells. And that can help determine how a tumor behaves, why it's growing, and also look for therapies that may be available for that particular tumor. It's common to mix up genomic cancer testing and hereditary DNA testing, otherwise known as genetic testing. And we just want to remember that genetic testing is different because it looks at the unique attributes of a person's full genetic profile and traits that may be passed down from generation to generation, as opposed to the genomic testing of the tumor tissue, looking at what's driving the cancer and what's developed in those cells over the patient's lifetime, not something that they were born with. Benefits of personalized medicine and cancer care. We'll talk just a minute about that. And we're here talking about genomic testing. That is an important part of precision medicine. It's a newer way to look at treating cancer on an individual level. And then rather than using a one-size-fits-all approach to treating the site of the tumor, the tissue it came from, like lung, colon, breast, thyroid, precision medicine uses the genomic makeup of an individual's tumor to better understand what is driving the cancer and how it can be treated or targeted. And a key piece of personalized medicine is that testing to identify these alterations that may be causing that cancer to grow and spread. Next slide, Kath. Yeah. So just talk just a minute about what types of tests are available. And there are a variety of tests, and you may have heard some of these terms from your physicians and healthcare providers. but there's a variety of tests that can detect fusions and alterations. One such test is, you can see in the upper left-hand corner, next generation sequencing. This is a type of test that can test for potentially hundreds of genes at one time and quickly sequence the tissue looking for those alterations. It's important always to talk to your doctor about which test is best for you and your situation. And remember that in most cases, solid tumor biopsies or tissue biopsies can provide more accurate or more information than liquid biopsy. So there are different types out there that can be done. But one picture I like to kind of paint here is, think about a dartboard. If you have a dartboard, some of these tests are throwing one dart at a time, trying to hit the bullseye and find out what's behind this cancer. Other tests may throw 2 or 3 darts at a time. But in the case of next generation sequencing, throwing hundreds of darts at one time at that dartboard, and that just increases the chance of hitting the bullseye and finding out what is driving the cancer and what can be targeted.
Okay. Thank you, Sherry. So now I'm going to take you on a journey of a tissue sample. So your doctor and testing lab teams work together to choose a testing method that will be the most effective in helping you to understand your tumor. So first, and this is an example only. So first, we're going to take the tissue from a biopsy, or a doctor collects or uses a previous collected from a small tissue, blood, or bone marrow sample. Then what happens, it goes for analysis. So cancer cells are identified and analyzed in a lab. Then receive the results. So the abnormalities are compared against known alterations, if there are any, that are related to currently approved therapies and those being evaluated in clinical studies. And then it's important to discuss results and potential treatment options with your doctor. Have a conversation with your doctor about what a treatment that will work for you. So it's important to have those conversations. Doctor, what would work best for me? Okay, and so now we're going to talk about how to start the conversation with your doctor, how to be your best advocate. These are just some questions that can help you feel empowered. So what are the different types of genomic cancer tests? Why is it important to get a genomic cancer test? Do you think I should receive a genomic cancer test? So how can I better understand the underlying genetic profile of my tumor if we don't find an oncogenic driver? Which type of genomic cancer test is best for me? What can genomic cancer testing find and identify? And how can the results of a genomic cancer test change my treatment plan? And I also wanted to note that you can download these questions on testyourcancer.com, and you can bring it to your appointment and have this discussion, with your physician. And also remember, the conversation shouldn't end when you walk out the doctor's office. Make sure you follow up after your appointment to continue that conversation. Make sure, you're fully understanding why it's being done, why it's not being done, and what those results read out to be.
I just want to talk just a minute about how sharing genomic test results benefits you and other cancer patients. Scientists are finding new biomarkers and treatments every day. And even if the right treatment for a particular biomarker or genomic alteration is not available yet, it could be in the future. So there are databases that are kept, and that's why it's important to store the results in the database, because we just don't know what's going to become available to patients in the future. And again, up to 49% of patients who undergo genomic cancer testing may have an actionable alteration, which means they could be matched to either an approved therapy or a drug that's in clinical trial. And that's important to think about too. And more than 100 targeted therapies are currently approved by the FDA, with more in development and coming available all the time. And then Kathy, one last slide, and we'll just wrap it up. Again, Kathy mentioned testyourcancer.com. There are more resources about genomic cancer testing available here, and I encourage you to visit the resource and download the resources that are available there as well. And with that, I just want to thank you all for being here today. And I will, Kathy, I think we can close our slide deck, and we're going to end the Bayer portion of the presentation now.
Right, I will start my screen share. All right, just to confirm that you guys see my slides. All right, so my name is Valentina Tarasova, and I'm endocrinologist at Moffitt Cancer Center in Tampa, Florida. I have a particular interest in thyroid cancer, both clinically and from research standpoint. And I would like to thank ThyCa to invite me to present. It's been really an honor to be part of that meeting. So with that, I will start talking about molecular testing overview for patients with thyroid cancer. So how my presentation outline, we will talk about genetic versus genomic testing for thyroid cancer. We'll talk about when to do a genetic and genomic testing. We'll talk about different methods of genomic testing for thyroid cancer, and we'll discuss clinical implications of molecular markers in thyroid cancer. I don't have any conflict of interest to disclose. First slide will be on germline versus somatic mutations, and just to highlight the difference between germline mutation and somatic mutation. Germline mutation is present in parental gametes. All the cells of embryo are affected, and all the cells of entire organism carries the mutation. So the mutation carrier can pass half of the, it has 50% chances to pass the mutation to the offsprings. As opposed to somatic mutation, they don't have abnormality in parental gametes. So embryo can be affected, but only specific area can be affected by that somatic mutation, and that could progress to adult life. But none of the person's gametes will be carry mutation, and offsprings will not be affected by a somatic mutation. So germline mutations are inherited, and they present both in egg or sperm. They can be inherited, and they can cause family cancer syndrome, like we know that in medullary thyroid cancer, MEN 2A or 2B. All cells are affected by germline mutations. As opposed to somatic mutations, they are acquired, and they occur in non-germline tissues. They cannot be inherited, and this is mutation in the tumor only. So for germline mutations, we do genetic testing. For somatic mutations, we do genomic testing. Genetic testing can be conducted on blood or on saliva. It identifies gene mutations that are present in every cell of the body, and it provides the risk for additional cancers, including the risk for the cancer itself. Genomic testing is conducted on tissue that is affected by that somatic mutation, or it could be done on circulating tumor DNA in blood. It identifies gene mutations that exist only in that tumor. Both genetic testing and genomic testing provides eligibility for targeted therapy if cancer progresses. So what are the genetic testing indications in patients with medullary thyroid cancer? So based on the guidelines from 2015, all germline red testing needs to be done in all patients with medullary thyroid cancer. So this will where we're looking for syndromes, multiple endocrine neoplasia 2A and multiple endocrine neoplasia 2B, or patients who have C-cell hyperplasia if they have their thyroid removed, and that was found on pathology. Also, patients who have first-degree relatives of patients who have proven medullary thyroid cancer. And also patients who, infants or young children, have classic clinical manifestation of MEN2B syndrome. This indication for medullary thyroid cancer genetic testing for these germline mutations. As opposed to medullary thyroid cancer, where everybody needs to be tested for germline mutations, in differentiated thyroid cancer, only few patients needs to be tested. So such patients, we typically have patients who come with one family member, and it does not really meet the criteria for germline patients. But the more first-degree relatives patients have with the differentiated thyroid cancer, these are the ones who will meet criteria. So basically right now, 2 or more first-degree relatives who have differentiated thyroid cancer meets criteria for germline testing. And also patients with suspected non-familial, non-medullary thyroid cancer syndromes. These are the syndromes like Cowden syndrome, familial adenomatous polyposis, Carney complex type 1, Werner syndrome, Dices syndrome. These are typically identified based on already known other types of cancers that patients have, and or specific genes that they already identify. In this case, we'll start looking for thyroid cancer and do genetic testing for germline mutation in differentiated thyroid cancer. So germline, when patients have genetic testing for thyroid cancer, we typically refer them to genetic specialists, and then genetic specialists do the pedigree, and they identify patients who are affected, their family members, and they create this pedigree for those families. Now I would like to switch the gears and talk about genomics of thyroid cancer, and to describe the different somatic mutations that could be seen in patients with thyroid cancer. So in general, a thyroid tissue has 2 types of cells, C cells and follicular cells. And these 2 types of cells give origin to 2 distinct types of cancer, as many of you know. So follicular cells give rise to papillary thyroid cancer, follicular type thyroid cancer, as well as poorly differentiated thyroid cancer and anaplastic thyroid cancer. So follicular thyroid cancer in general have two distinct lines, 2 different type of pathological and genomic findings. First one's the one that papillary thyroid cancer like BRAF-like or RAS type of lesions, so giving rise to papillary thyroid cancer or follicular type of thyroid cancer. So majority of the papillary thyroid cancer is driven by the RAF tumor, as well as RAS and TRK fusion, RET fusions. And follicular thyroid cancer is mostly driven by RAS, APAX8, PPR gamma, as well as Hürthle cell type of cancer is part of follicular thyroid cancer, and this is molecular marker for that is increased number of chromosomal copy number alternations. When there is accumulated burden of mutations, papillary thyroid cancer and follicular thyroid cancer can progress to polydifferentiated anaplastic, and then when we see that distinct also molecular profile with higher burden of mutations such as TERT, TP53, PKI3K, AKT, so different additional mutation build up in the tissue, and then they cause progression. Sometimes follicular cells like manifest, there is not really seen that progression, and then it can present itself as give rise to poorly differentiated anaplastic right away. So, and again, this is very simplified, of course, presentation of genomics of thyroid cancer, but that will serve for the purpose of this presentation. So genomic testing indications for thyroid patients with thyroid cancer is when the cancer is progressive and it is metastatic thyroid cancer, and when we really think about systemic therapy. It's also a new indication for genomic testing is before actually patients who present with advanced disease in the neck that cannot be really resected well. And in these patients, we are now knowing genomic composition of the tumor can consider neoadjuvant therapies. Neoadjuvant therapies are the therapies that could be given before main therapy like surgery for thyroid cancer to shrink the cancer before surgery. So this is somewhat new indications, and this is also in development and in the clinical trials. But for locally advanced thyroid cancer, this is something that can be considered. Also, genomic testing is now considered for thyroid cancer risk stratification. Again, this is a new direction, but however, it will definitely will hear more about that in the future. Genomic testing for indeterminate thyroid nodule has been very has been used for many years, and we know a lot about it. And it was used for patients with indeterminate thyroid nodules. So gold standard for genomic testing for thyroid cancer is actually tumor tissue analysis. However, there are different types of genomic testing that we can do in patients with thyroid cancer. So for tumor tissue analysis, we use a next generation sequencing, which is basically the gold standard. And this is something that is typically advanced panels that could be used for different types of cancer, including thyroid cancer. Then there is a method that is called immunohistochemistry. This is a method that's been that we have a lot of experience with that, and it's been used for both for diagnosis of thyroid cancer as well as for diagnosis of specific mutations in thyroid cancer. There is also something that RT-PCR, reverse transcription polymerase chain reaction. This is the method that is used typically to identify specific mutation in thyroid cancer. And then there is a method called FISH, fluorescence in situ hybridization, that is typically used for research purposes and not as much used in widely used in clinical practice. This is an example of immunohistochemistry that for BRAF V600E mutation. So in this case, we need a tissue sample, and it's typically the surgical specimen that's been embedded in paraffin, so like tissue stored from thyroid cancer. And we basically use the antibody of BRAF V600E antibody, and that is help us to identify if that specific tissue have this specific mutation. So the pros of that method is that it has pretty rapid turnaround time. So it takes actually, it's a very good method for if we know what we're looking for and if we need a fast answer. But it's only looking for one mutation, not the whole panel of the specific mutation. The good thing is it's very inexpensive, and it's typically covered by insurance. The cons is that because it's only one panel, typically one gene at a time that we're looking for, so it's we cannot have, if one is negative, we typically need to go for another one. So it's not really, we don't have like a really well-established pathway now to do one gene after another. More than this, the immunohistochemistry is not really developed for different, for novel gene novel gene mutations that we see in thyroid cancer. So like we don't have the widely clinically available, let's say, RET mutation analysis or and TRK, or so it's not still, this is all still in development, but BRAF is there. So the other limitation of this test is that only specific amount of tissue is needed, and if this tissue is not available, we cannot run this test. So tissue next generation sequencing is that comprehensive genomic profiling that is typically, it depends on the company that does it, includes definitely way over 150 type of genes, and it could be specifically targeted for thyroid cancer patients, or it can be different, used for different types of cancer, more over pangenomic type of testing, so that is not really specific for thyroid. So next generation sequencing looks for genes for cancer relevant mutations in the DNA. It also looks for microsatellite instability, tumor mutation burden, and PD-L1 immunohistochemistry. So it does not look also only for mutation, but it looks also in other features that can be used as also as indications for the future therapies. Okay. So I would like to spend some time talking about liquid biopsy, because this is a newer technology that can be used for patients with thyroid cancer. So liquid biopsy is that for liquid biopsy, we don't need to have tissue for the analysis. So that biopsy could be done on the circulating tumor cells or circulating cell-free DNA in that the markers that material is present in bloodstream. So there's special technology that is used to subtract the material, and we can run specific mutation. Let's say we want to know if the cancer is BRAF positive, so we can see if there is BRAF V600E mutation present in the bloodstream. And that's been studies that looked at that and looked at the BRAF V600E as well as RAD M918, but ultimately different types of mutations could be looked at. Again, this is not really widely used. Assays in thyroid cancer was mainly used in research, but since, like, for example, that's been more commonly used in melanoma, I think that these technologies will be coming for thyroid cancer itself. So I was talking about liquid biopsy for specific mutation, but we can do also liquid biopsy for comprehensive next generation sequencing that will implement like whole genome sequencing in patients with thyroid cancers. The advantages of this test is that there is no need for the tissue samples. So we don't need, let's say, to obtain newer biopsies, or we don't have to request like previously stored tissue sample that was, let's say, on the surgical specimen that was on the surgical specimen that was, let's say, surgery was done 10 years ago. So we can just draw the blood and see what the mutation, what is the genomic, next generation sequencing in the blood. This is a big significant advantage. On the other hand, it also has pretty faster turnaround time, particularly if we take in consideration the need for additional biopsy or the time that will take to get this tissue analysis, tissue specimen. However, the disadvantage is that it's not been really well validated in thyroid cancer yet. It's very non-specific. So let's say if the patient has other type of cancers, this material and this mutation will also be detected in blood. So it has significant limitation. Also, we don't know if, let's say, patients have low burden of disease or not really, the cancer is really rapidly progressing, how much really it will be sensitive to detect, how accurate it will detect these mutations in blood. We don't know that yet. Also, disadvantage is it's more costly, of course, somewhat more costly compared to other type of testing, but it's pretty similar to other next generation sequencing technique like tissue next generation sequencing that has similar costs.
Just quickly, Doctor, I just want to let you know you have about 20 minutes left. So if you want to gauge your slideshow, okay.
I think I'm still on track, but yes, thank you. Thank you for heads up. So molecular testing for thyroid nodules are also something that's been widely used, and it's typically used by Bethesda 2, Bethesda 3, 4, and 5. And this is the most common methods those are the companies that are doing this molecular testing: Thyroseq, Afirma, Thyromir, and Thyrogen. Those methods are used to establish diagnosis, that help us to establish diagnosis of cancer and also to help to determine the extent of surgery. However, this is the same next generation sequencing, but however, and then the Afirma that does it a little bit different. They look for the molecular classifier. However, though some of these tests has been used also to risk stratify already not indeterminate thyroid nodules, but it has been used to stratify thyroid cancer. So knowing, let's say, mutation in the cancer, maybe also we can actually predict the risk of distant metastases And based on this molecular profile, we can determine like if the patient is at high risk or medium risk or low risk for developing of distant metastatic disease. Again, this is not widely adopted technique, but probably I'm sure that these things will be coming in the future for patients with thyroid cancer. So what are the obstacles for molecular testing? Molecular testing assay viability. So definitely in the United States, we have certain profile. However, in other countries, we may not have we may have different testing and companies who are doing this testing. Then we need to have typically for the next generation sequencing, we need to have tissue viability. For immunohistochemistry, we need to have tissue viability to assay turnaround time. Sometimes, let's say for patients with anaplastic thyroid cancer, we need to have that answer pretty fast. So we cannot really afford to wait for 3 weeks to have that. So that's one of these things that we need to consider. Coordination between multiple providers. That's why patients with really aggressive advanced thyroid cancer will benefit the most from the care at multidisciplinary, at the tertiary center, where they have coordinated visits among the providers, among surgeons, pathologists, radiation oncologists, endocrinologists, medical oncologists, who will all where all this testing could be done simultaneously, and results could be given in a timely fashion, and the decision could be given timely, and the choices of the clinical trials could be given to the patients earlier. So ability also of ability to interpret the results is also one of the obstacles to molecular testing, because the let's say the liquid biopsy is not really widely used, so that requires more specialized expertise in that setting. When to be tested for when the patients need to be tested for genomic testing needs to be done. So American Thyroid Association, interesting to see the evolution of the recommendations for genetic and genomic testing. So for genomic testing, back in 2015, that's the most current updated guidelines for differentiated thyroid cancer. They actually, back then, there was not significant information regarding targeted therapy and mutational profiling was not been really emphasized in the guidelines. So they say that basically mutational profiling for metastatic thyroid cancer has not definitely proven to be of value to estimate the prognosis or predicting response to therapy. However, since 2015, there have been a lot of studies that really change our understanding of genomics of thyroid cancer. And now in 2021, let's say American Thyroid Association guidance for anaplastic thyroid cancer say that molecular profiling should be performed at the time of anaplastic thyroid cancer diagnosis to inform the decisions related to use of targeted therapies. So differentiated thyroid cancer updated version will be coming soon. So I'm sure that there will be some changes in recommendations from that standpoint too. NCCN, this is guidelines that are updated on yearly basis, and they are in 2021, they recommend genomic testing is indicated to identify actionable mutation for advanced progressive or threatening disease for thyroid, for the patients with papillary and follicular thyroid cancers. For anaplastic thyroid cancers, molecular testing is for actionable mutations is indicated too. But they don't recommend what type of testing done and the choices and the timing between different testing. So why the testing needs to be done? Because we are recognize that precision medicine has significant advantages for the patients. It leads to improvements in treatment efficacy, improvements of quality of life for patients, increases survival rates. Targeted agents are better tolerated. It mitigates unnecessary treatments. It allows participations in different clinical trials. Cancer risk stratification is possible with patients with whom we know genetic profiling, and it also helps to predict response to therapy. So this is the timeline of FDA-approved therapies for advanced thyroid cancer over the last couple of years. And for many years, we don't have any activity for patients for thyroid cancer. So since 1975, when doxorubicin was approved, which is a conventional chemotherapy for thyroid cancer, there's been not much going on until 2011. And ever since, there's been every year or so, a new therapy has been approved for thyroid cancer. 2011, vandetanib has been approved for medullary thyroid cancer. 2012, cabozantinib for medullary thyroid cancer. 2013, sorafenib has been approved for differentiated thyroid cancer, and lenvatinib in 2015, larotrectinib in 2018, and tractinib 2019 for tumor agnostic therapies for NTRK positive thyroid cancers. Dabrafenib and trabectedin was approved for BRAF positive anaplastic thyroid cancer. Selpercatinib and pralsetinib had been approved in 2020 for RET differentiated thyroid cancer with RET fusions or medullary thyroid cancer with RET mutations. And most recently, in 2021, cabozantinib has been approved for treatment as a second line for differentiated thyroid cancer. So every year we can offer more for patients with thyroid cancer, and many of these therapies are specifically targeted based on the genomic composition of the tumor. So here is the table that reflects actionable biomarkers, biomarker-driven therapies for patients with thyroid cancer, metastatic thyroid cancer. So for patients for BRAF indications, for anaplastic thyroid cancer, for differentiated thyroid cancer, patients with RET alterations and ThyRK fusions, for medullary thyroid cancer with RET mutations. There is also options for, now patients have options for neoadjuvant therapy, as I mentioned above. More than this, it is in the guidelines. So NCCN guidelines in 2021 said that the regimens that can be, outline specific regimens that can be used for neoadjuvant therapy. Again, neoadjuvant is the therapy that could be used before surgery for the patients who have pretty advanced disease, who are not great surgical candidates, and who may have non-resectable disease. These patients we can pre-treat based on their specific mutations, pre-treat with certain regimens, and then shrink the tumor before surgery, and then have better clinical outcomes after that. This is also investigated currently in clinical trials for specific mutations, but dabrafenib and trametinib could be considered for the BRAF positive tumors, selpercatinib or pralsetinib for RET alterations, positive tumors, and larotrectinib or entrectinib for NTRK positive tumors. The other clinical implications for understanding genomic mutation would be for the redifferentiation clinical trial and clinical therapy. Again, I would like to touch really on that topic because it's pretty significant. Time could be dedicated to that, but the concept is that some thyroid cancers lose the ability to pick up radioactive iodine, or don't have the ability to pick up radioactive iodine to stop that. And the concept is that there are certain genetic mutations, genetic mechanisms that lead to that. So if we can reverse cancer ability to pick up radioactive iodine, we potentially can have pretty effective treatment for patients with the differentiated thyroid cancer. And response to therapy, whether they will respond to that, to redifferentiate agents or not, also depends on the mutational status. Selection of redifferentiation agents can be also done according to the specific mutation. So that's why it's important to know the genomic composition for that consideration too. So, and in my last slide, I would like to outline the future directives of genomic testing in patients with thyroid cancer that will allow us better risk stratify patients. For now, we mainly use clinical characteristics and pathological characteristics of thyroid cancer. So, but definitely understanding genetics, and genomics of thyroid cancer will help to future re-stratify patient. It will also help us to determine the extent of surgery. It will help to understand maybe better in the future the response to therapy of certain systemic agent or surgery or radioactive iodine. It will also help us to determine follow-up frequency and modality of the follow-ups that we do for patients for thyroid cancer. And it will definitely allow better treatment option and selection for clinical trials. With that, I would like to thank you for your attention, and I will be ready to take questions. I will stop sharing the screen now.
Thank you, Doctor. Can you see the questions?
Yes, let me just stop sharing. Just a second.
I had put in the chat my email support-coord@thyca.org. If any people who have asked questions want to privately email me with their names and maybe the questions they asked, because this is being recorded and we can send the questions to Dr. Tarasova to answer afterwards. So that would be private. So look at the chat for my email. Go ahead, Doctor.
So the question number one was about basically a case of a poorly differentiated thyroid cancer that's been treated with total thyroidectomy and had rather rapid recurrence, or there was significant, so there'll be significant tumor growth, like up to 5 centimeters only 4 months after radioactive iodine therapy. And it seems like the tumor was positive for red. Seems like because the tumor was treated radioactive iodine, I think it was red fusion, and it was follicular cell derived thyroid cancer, and it also had many other mutations like TERT, CDKN2A, CKN2B, and TAP. And we see that typically for this is exactly the case where we have driver mutation that was likely red fusion with different acquired mutation later on during course that led to that differentiation. So that, like they call it, late hit mutations, and definitely that could be seen and poorly differentiated. And if the question was if it's this mutation could be seen in ATC, definitely. And it's the thyroid cancer represents a spectrum of disease from really well differentiated thyroid cancer to poorly differentiated anaplastic. And where we capture that based on pathology, that's what defines that pathological diagnosis. However, mutations can still may definitely could have led, if that cancer would be there, it's possible that that could have led to anaplastic thyroid cancer overall. And even different poorly differentiated it's different from one from another because of that mutation, probably composition, and other factors. So yes, it could be definitely seen in anaplastic thyroid cancers as well.
We have like 5 minutes left. We might be able to go over 5 minutes more. We might be able to.
Let's see. Perfect. So there was another question on recommendation for Germline mutational platform. The decision. So in the past, when now we can do one platform that captures a lot of genes that we test for. In the past, we could do only one at a time due to different reasons. First, the platforms were not available, and definitely the cost. So what happened in the past with medullary thyroid cancer, one gene at a time was tested, the most common one, or the one that was, let's say, was suspicious clinically based on the other clinical characteristics. Right now, let's say for medullary, there is like a multiple gene panel that we're testing. Let's say for the patients with differentiated, so it all depends on the clinical suspicion that on the clinical profile that patient come with. Let's say if they come with the signs and symptoms like, let's say, of Cowden syndrome, of course, we'll select specific the platform for that type of cancer. Typically in big tertiary centers, we have specific team. We have specialized team that address all these questions. So we just, when we have the candidate, we send them to this testing, and that the team addresses all these questions, and then they basically provide that. They also add their expertise to that panels. So the other question is there why isn't genomic testing called out as a standard of care? It probably will, because it's still in development. It still will learn more and more. And I think that an example with guidelines was a good kind of example how the field is evolving. When we do something in thyroid cancer or in any type of thyroid cancer, we need to understand what will be the clinical implications, what we will do with this information. And until it will be really a good validated clinical data, that cannot really be widely adopted, like among all the patients. So it could be done part of research, but it cannot be really done as part of that generalized guidance for the patients with thyroid. It definitely will be coming in one form or another in the future, yet we need to collect more information for all that information. There was a question regarding, I think that there was, maybe I don't see them all, but there was some question asking about specific nutrition panels for the testing, and it's not definitely been validated in thyroid cancer patients. And again, we have to look at the data itself, but I think so far it may not be harmful, but again, what we would be doing with that information and with the really clinically validated information in thyroid cancer, it would be difficult to give any recommendations. We have also a question about $6,000 for the test, and many of us have to pay. That's why it has to be specific indications, So if there is, let's say, the test that we know that will be now it's more there. It's once we have targeted therapies like larotrectinib, entrectinib, sopracantinib. Once we have these targeted therapies, we can actually authorize more of this. We can get authorization from insurance companies to cover this more. In the past, probably it was not as much, because it's not as much in the guidelines. And once these guidelines will change, there will be more opportunities.
We can go over till 12:35, and that's it.
Perfect. For 5 more minutes. If you have papillary thyroid cancer follicular variant, are you likely to have the mutations of follicular or papillary thyroid cancer, of mutations of follicular or papillary thyroid cancer? So papillary thyroid cancer has mainly two distinct, mutually typically exclusive mutations, which is BRAF and RAS. BRAF is typical classical papillary thyroid cancer. RAS type of tumors is the ones that have follicular and follicular variant type of thyroid cancer. So clinical pathological features and also the behavior is different. So follicular variant papillary thyroid cancer, typically RAS, but could be BRAF too. My son, age 11, at the time has papillary thyroid cancer, was tested for EMN1 in 2012. Results came back negative. We were told that he fell in the 10% of unknown. He ended up with PTC. Should have the same test redone. Definitely, the patients who've been tested in the past will probably, and there was no really definitive answers, and you feel that something is going on and there are additional things. Definitely, this field is evolving so fast. So more updated therapies, more updated testing could be beneficial, because we can find new mutations that are discovered. But thyroid cancer is a common type of thyroid cancer, so it could be frequently, found, particularly if we're looking for that.
Valentina, could you address people who, have asked their doctors, about the testing and the doctors refuse? What options do patients have? I know.
So, and I have to say that I sometimes say no too, because it depends what we're looking for. For example, for patients why we want to have do we want to have genetic testing or genomic testing? If it's genomic testing, it has to be done like medullary thyroid cancer. Again, you go through indications. If you have many family members, of course, many types of other types of cancers, you suspect other syndrome, definitely agree. If you, let's say, have metastatic thyroid cancer that is progressing, yes, for sure, because that will drive the mutation. If this is the case, just keep asking, look for, like thyroid cancer has, ThyCa has, for example, a lot of support, like previous, there are a lot of websites and that that help to, like Katie and Sherry shared some of these questions that could be used to make to bring this conversation with the doctor. On the other hand, sometimes not every thyroid cancer needs to be tested now, because again, we don't know what to do with this situation in clinical practice. So it may not be covered by insurance. Yet, if we know that, that's always helpful and useful. And like personally, I will never say it will always be helpful to know genetic composition. It does not mean that I will act on that, but it's always a useful piece of information to have.
Thanks everyone for your attention, and thanks for having us again.
Yeah.
Thank you so much.
You have a great Sunday.
Thank you.
Take care, everybody. Be well.
Bye-bye.
Goodbye.